I'd like to introduce our second speaker. He is someone I've known and worked with on many projects over the years, as well as a previous RSI Day presenter. In October, we both co-presented on the impact of workers not seeking medical attention for their pain and the fact that many were working injured and actually becoming addicted to opioids in order to be able to complete their work. This time I'd like to introduce Carmine Tiano, Director of Occupational Services from the Ontario Building Trades Council of Ontario, to present on the chronic musculoskeletal pain and opioid misuse. Carmine?
Yeah, thank you, Trevor, and thank you everyone that's taken time to join us this morning. Catherine, thank you for providing such an eloquent, your journey got here. Some of the points you brought up, I've actually put in my presentation. So I think you are a leader in this, and I thank you for the work you've done for the last 30 years. What I would like to do, why is it not working now? Kind of slowly. Oh, okay. Sorry about that. Yeah, I'd like to first go through a brief overview of what the Provincial Building Construction Trades Council of Ontario is. The Building Trades was established in 1957. We're the umbrella organization of all unionized construction in the province of Ontario. Presently, we have 16 affiliated construction trades with well over 200,000 members. So these are the unions that make up the building trades. As you can see, we basically deal with every sector of construction. And within the building trades, we have 30 construction trades, which deals with laborers, carpenters, electricians, painters, plumbers, operating engineers, boiler makers, and which make up the biggest contingent of the workforce. Interesting, the building trades is involved in all sectors, residential, heavy commercial, the power sector. And within the trades, you have subspecialties. The background. The construction background is interesting in and out of itself to understand why the program with musculoskeletal pain and opioid and substance use. I use the word use, not abuse, because let's go through the background. We all know the workplace accidents and occupational disease affect construction at higher propensity than other trades. Whatever numbers you may see in your various places where you live in country, I can almost rest assured that the numbers are underreported. The true burden of disease and musculoskeletal or other injuries is still a bit of an issue. The construction sector is different than any other industrial service sectors because a typical construction project only employs workers for the duration of the project. Most of the workers in the unionized construction sector are dispatched to employers in the ICI, Industrial Commercial Institution, for example, for the duration of that project through a hiring hall. And they can only work for a couple of months. The adage goes in construction, the quicker you work, the quicker you are out of a job. And sometimes the quicker you work isn't the best for your physical or emotional health. There is little continuity in the workplace. That's extremely important. I know that we hear talk about, well, joint occupational health and safety committees, disability management committees, ergonomic committees. The lack of continuity and attachment to a workplace, the size of the workplace makes it very difficult to put in the interventions we know that which can deal with the musculoskeletal injuries and the occupational disease injuries. Additionally, the trades employed on a construction project differ considerably from one another. The conditions of a carpenter are different than those of an iron worker. And each trade has their own unique tasks and their internal procedures to deal with workplace issues. In addition, the trades and individual construction locals are basically autonomous entities. This means that the local unions within the same trade may have different procedures to deal with the workplace issues. Example, two bricklayer locals, although representing the same type of workers, may not share the same internal procedures. So this is the background. So construction, in a nutshell, you have various trades working together, sometimes on the same project, various cumulative exposures, and short duration. So, opiates in construction and what's actually happening. A few years ago, there was a real good report that was done. It's called Changing Circumstances Surrounding Opioid-Related Deaths in Ontario during the COVID-19 pandemic. Interesting that there is a perception that March 13, 2020, the floodgates opened and opiates became an issue in heavy industry or in all industries, as a matter of fact. No, the reality is that this has been something that has been on the radar for the last 10 years, and it only took the world a pandemic to bring to light the issues with opioids and heavy industry and the lack of support to these workers that may be suffering from any type of addiction. We're dealing with opiates, but other addictions. So this report actually looked at that of nearly 2,500 opiate-related reported in Ontario, 30% were employed in the construction industry. Here's the actual breakdown of opiates in construction, and as compared to other sectors. You can see construction is the highest, but is other sectors that are implicated with opioids as well. Men in the trades are disproportionately impacted. Since 2016, some other stats, around 3/4 of opioid-related deaths were men. Men in trades are overly represented. Of people who were employed at the time of death, 30 to 50 were employed in their trades. Interesting enough, there was a review done by NIOSH, I believe in 2016, that compared suicides, opiate, and deaths, and opioids was implicated even in the United States. So there is a correlation, not only in Canada, in North America, and some of the other work that I've seen across the world. So this is not a phenomenon only in North America. It's a phenomenon in most industrial G20 countries and in any type of heavy physical labor. So there is this idea of hard physical labor takes a toll on the body. There is an increase to risk of injury and can result in pain. Now, I think that when you look at pain medication like prescriptions, they can actually be to help abate the pain. But unfortunately, due to some other risks that I'm going to go through in a minute, the actual prescription of opioids become the only modality provided to workers. Now, this is the biggest issue that we see in construction, this work hard, play hard mentality. Many trades, workplaces have a work hard, play hard culture, especially outside of work. Men are more likely to use and misuse substances to cope with stress and or mental health issues. Men are less likely to reach out for help because there is the pressure to be strong. That is a big, big issue. So this work hard, play hard mentality is still something that's unfortunately prevalent in the construction environment. Now, interesting enough, in 2020, the De Novo Treatment Center, which I believe that this presentation will be made available and you could actually go in and hit the link. The De Novo Treatment Center is a construction jointly funded employer union treatment facility just north of Toronto that deals with workers and family members who've had issues with substance use, alcohol, drugs, etc. They did a study in 2021 and titled 5 Drivers of Substance Addiction and Suicide. Now, you can see that they categorized the actual drivers. The number 1 was work habits and schedule. Number 2 was personal relationship. Number 3, stress, anxiety, and depression. Number 4 was finances. And number 5, discrimination and abuse. So what De Novo did, they took a sample of construction workers that have gone through their program, very innovative program, I think one of the best when it comes to substance use for workers in construction, and they identified these drivers. To break down the drivers a little bit more, you have the idea of number 1, work habits and schedule, 44 to 49%. Physical pain due to kind of work involved was predominantly mentioned by the those who responded. Long working hours, not eating properly, unhealthy lifestyles. Number 2, the actual personal relationships. This is a big one, staying away from home for periods of time. One thing in the construction background that I'd like to stress is our workers can be dispatched to very remote areas that are going to be living in a remote work camp, staying away from home, having access to large amounts of money, sometimes is not conducive to maintaining good personal relationships. So that came up in the De Novo survey. Another one, stress and anxiety. 40 to 41% work-related stress, sad and depressed, hopeless, feeling anxious, restless, or uneasy. So interesting enough, people with mental illness are twice as likely to have a substance dependency compared to the general population. That's an interesting study that I added to the slide. Finances, financial security. People are going, yeah, but Carmen, you just said that your workers are paid very high. Yes, but if you go back to the way I premised it on the construction background, the not the instability, the actual nomadic work, job to job, the quicker you work, the quicker you're laid off. When is your next job gonna come? Sure, the wages are high, but that actually has a burden on someone and is a driver. Discrimination and abuse. I would have thought this one is a little bit higher, but in here includes bullying by colleagues and or supervisors, on the job site, physical, verbal, or mental abuse, difficulty with fitting in with colleagues. All these have been drivers towards drug dependency. Yes, I just saw the slides will be available, I believe it. Now, here's another interesting point. Catherine, this is why I think it was brilliant for Catherine to start this off. She talked about the issues she had with compensation in her journey to that black hole, which was kind of still, I've kind of heard her speak a couple of times, but the black hole is very, very troubling to me in the sense that how can someone go to that point? So one of the areas she talked about was the compensation language. So I put this in as a barrier. Stigma in compensation landscape is not supportive. Very important. Many construction workers do not report wear and tear injuries due to stigma and fear of employer retaliation. Look, I'm not saying that every single worker who puts in a claim for workplace insurance is going to have a target on their back. But unfortunately, this does happen because putting in a claim will lead to potential increased premiums on the employers. So there is maybe not a covert, so not an overt threat, it's the covert threats. Even when wear and tear injuries are reported to a compensation provider, not only in Ontario, they are routinely denied. In Ontario, the Workplace Insurance Board has had this real aggressive approach to adjudication of especially gradual onset type of claims for, I believe, they actually, for the last 10 years, too often gradual onset claims are denied, even when almost all the medical evidence supports a workplace connection and a nexus. Now, attributing ongoing symptoms to a pre-existing condition has become the main tool to limit benefits for work-related injuries. WSIB regularly denies ongoing entitlement where workers have not recovered from a strain based on usual expected healing times. Older workers have been especially hard hit. WSIB informs these workers their injuries should have healed, blames any ongoing symptomologies on age-related degeneration. Interesting enough, across a spectrum of heavy industry, the average age of work in the trade is north of 40 years old, maybe even 45. So the manner in which the board, not only Ontario, this is not an Ontario specific problem, it's a complete problem across Canada. Older workers are being hit hard with the actual, everything is related to age. Now, what does this mean? Workers just simply do not claim for benefits. They continue to struggle with the pain. And how does this happen? They go into a cycle. Carmine is a fairly healthy guy, but he wants to continue to chase the money. There's good jobs out there. So what does Carmine do? He has pain. So Carmine starts with the easy thing. He starts maybe self-medicating with alcohol. Then what he does, he starts using maybe marijuana. Then he moves into prescription legal or illegal type of opioids or other substances. Then that starts, there is no reversibility in Carmine's condition. Worked 6 months ago is not working now. Then Carmine completely goes down this road. Now, physical pain, there's also a psychological component going on. Then Carmine moves over to some real harder type of drugs. If Carmine would have had a landscape for him to put a claim in, have a receptive compensation provider that provides what Catherine said, the appropriate treatment, maybe Carmine wouldn't have gone on that road. Now, WSIB adjudicators do not take time to even interview a worker to understand the task performed or equipment used. One thing that's very important to understand about the construction environment, a worker could be being hit with multiple physical stressors, vibration from a jackhammer, loud noise, solar exposures. All these are acting sometimes at the same time. It's very, very important that the finder of fact, a doctor, even a doctor, understands what this worker is doing, understand the task performed. That doesn't happen. Obvious. Often previous claims are ignored or used against the work, against an injured worker. Loopholes such as timelines to file. What I mean by this, most jurisdictions across Canada have a time limit that says someone needs to put in a claim 6 months from when you determine or when you become aware of that it's work related. I've seen situations claims are denied. Well, your doctor told you in 2022 that this was work related, but you didn't put it in. You knew. So now you're fighting the time, the actual loophole. The other one, claims. I shouldn't have used ignorant. I put it in. It's there. Claims denied based on ignorance of adjudication. Unfortunately, any type of system like WSIB is based on to frustrate the worker, make tedious situations so they can just drop or abandon the claim. Now, the other situation that's problematic is this one: reluctance of workers to report and seek treatment, social stigma, and potential for job loss if opioid use becomes known to co-workers and supervisors. I think this one over here is very problematic. And if Carmine doesn't have the assurances or the ability to reach out, because if he reaches out, he's going to be looked as being weak. Whatever modalities, interventions we put in, unless we break that stigma, will not. We won't be able to be successful. This one, I talked about that. A major issue which Trevor and I are, Trevor had a fantastic presentation titled something like this. How can we get to a solution if we don't know what the actual problem is? There is such an underreporting of injuries in the construction and heavy industries. There is a real underreporting. My perspective is that health and safety statistics is a Potemkin village. The stats basically show, if you look at per 100 injuries per 100 workers, they're fairly low in the construction sector. Construction in Ontario has six sector groups. They're basically around, I'm just looking at some of the numbers. The highest per 100 workers is 1.32 injuries per 100 workers in residential construction. However, friends, if you look at the no loss time claims, these are injuries that really happened that have been reported but are being managed. They're anywhere from 200% worse to 400% worse. So we really have a Potemkin village when it comes to reporting of statistics in the construction sector. On average, 20 workers die a year for the last 20 years in construction. Critical injuries are always going up, but yet no lost time injuries are basically below more sophisticated employers in Schedule 2. That's a problem. I believe that the underreporting of injury obscures a relationship between workplace physical demands, pain, and opioid use. Because if you look at the stats, hey, you guys are doing pretty good. No, we're not, because a lot of these aren't actually registering in the system. Oh, sorry. Now, one thing I think that's interesting that I want to talk about. Now, this could be scary to certain people. There is a body of literature that says, all right, maybe we need to look at moving towards what's called a total worker health perspective. NIOSH has done some work on this. And let me preface before I go into this right now. I'm not advocating any kind of behavioral-based safety. A total worker health perspective is a basically all-encompassing way to look at, we have a problem. Let's look at a way of looking at all of it together, looking at the whole perspective to look at a better way of looking at occupational health and safety. So the worker health model is relevant because opioid use can involve both personal risk factors such as age, gender, fitness, occupational identity, and health history. It also has workplace factors such as physical demands, hours of work, job insecurity, time pressures. Interesting on that one. If you remember when I talked about the 5 drivers, the actual people that had issues with substance use brought up workplace factors, physical demands, hours of work, and insecurity. Work-related back injuries, for example, are common in construction industry and frequently lead to opioid prescription. That was one of the examples. Now, here is moving towards total worker health perspective. The worker health perspective is defined as policies, programs, and practices that integrate protection from work-related safety and health hazards with promotion of injury and illness prevention efforts to advance worker well-being. That's what we want. We want to get into a worker well-being. Now, the TWH perspective examines the shared responsibility and opportunity for health and well-being between those who control the conditions of work. This is just the model. Now, what I did is this. I'd seen various presentations that lay out what the issue is, but no one has actually attempted to lay out where do we go on a policy program activities across a continuum of care. Continuum of care could be government and government, unions, etc. So I'm going to just briefly go through this, but again, the presentation will be available. So what I did is I tried to break things down. So government, problem. I addressed the problem of compensation landscape not being supportive. Actions, review workplace insurance, entitlement policies, gradual onset claim, and mental stress. Interesting enough, in Ontario, we really haven't had a robust and worker-focused workplace insurance system. Right now, what is interesting is this. Employer premiums have gone down. That's cool. The unfunded liability, which in 2011 was $14 billion, there was a Harry Arthur's review that had a regulation that said the WSIB would have to pay off the unfunded liability by 2027. Their unfunded liability was paid off by the fourth quarter of 2018 or 2019. Their funding ratio now sits at 118%. For them to be fully funded, it doesn't have to be 100, but their definition of fully funded is 110 to 118. They're at 118. There is $1 billion in surplus going back. I believe some of that money, instead of going back to premiums, could go to looking at a worker-focused system that provides not only the entitlements, the treatments that people need so they don't go down the black hole. Number 2, government, few non-pharmacological treatment options available for acute or chronic pain. Provide local community access to high-quality pain management programs that apply behavioral principles, interdisciplinary care. Use a biopsychosocial framework. Government, health and safety, working conditions. Look at ongoing inspections. Enforce targeting and musculoskeletal hazards and workplace hazards. We have the money there. There is the money. And by the way, by doing this, we're not tapping into the tax base. We're looking at the surpluses that already exist through employer assessment rates. Government. Catherine talked about it. The musculoskeletal injuries. So let's look at a musculoskeletal injuries as, currently, musculoskeletal injuries are approached as a singular localized issue. If we follow a biopsychosocial emotional model, but you look at injury, pain, treatment, management, and expand research to what exacerbates musculoskeletal injuries, we may be able to target these situations. Here's another one, what government employers and unions can do. There's limited awareness of job musculoskeletal or biopsychosocial emotional expectations, exertions, and strains. So why couldn't we provide operational evaluation of MSK, expectations, exertion? These tools exist. OCAL has created them. The Center for Musculoskeletal, the Center for Research Expertise at the University of Waterloo has these tools. These tools exist. All right, we need this. Another problem that I've identified that can be done by employers, government, and union. The prevailing approach to MSK injury is avoidance and is symptom reactive. Provide proactive, restorative programming and resources, active wellness, things like this that we could actually do. Again, government, what employers and unions can do. Healthy, here's the problem. I've called it healthy, not healthy perspective of pain and injury. Can be exclusionary and divisive. Expand perspective of injury and pain to include a graduate assessment of an incident and accessibility to non-opioid-based resources. There are non-opioid-based treatments that can happen. Here's another one, and this is what talked about, I believe, when she had a press conference to try to get, we do not have a musculoskeletal strategy in Ontario. The only jurisdiction that came close was Washington State back in the late 1990s, and it was blown out when there was a change in government. We need to be looking at a successful management of musculoskeletal injuries, and there's a wide base of interventions that can be done. Another problem, absence of research on workplace factors and interventions to prevent opiate-induced deaths. Here's something that the employers could. Workplace occupational health and safety programs are not holistic. Conventional health promotion practices generally focus on personal risk factors and individual behavior. What I'm proposing is that we move to a total worker health model. I know some people would be scared, oh, Carmen, you're going to be bringing in behavioral-based safety. I'm telling you, that's not what this model is. But again, let's have a grown-up discussion and say that the current programs are working despite since 2013, Ontario spending north of $2.4 billion on prevention services, our numbers are still pretty bad. We may need to be looking at another model, or at least have the discussion in what employer and unions can do. Workers' education about risks and treatment. Well, expand existing safety, apprenticeship, and workers' wellness training programs. This can incorporate information about opioid risks, non-pharmacological pain management alternatives, in basic training. We're actually doing this in the trades in Ontario. I partnered with St. John's Ambulance to deliver a construction-specific opioid program that we're bringing to our pre-apprenticeship journeyman. So we're already doing this. Another one, employee assistance programs. This is extremely important. What unions can do. Ensure that appropriate supports are provided to members for musculoskeletal pain and mental health. Quality assure the programs. Make sure when Carmen reaches out that needs help, the programs are there. Again, there's a little bit more. I've gone through a lot of issues. Here's what government, employer, and unions can do: limited incorporation of trauma-informed practice to support musculoskeletal pain and injury. Then I give a rationale why. Limited work education on practice specific to opioid misuse and harm. Again, we're trying to address that. Worker. This is a problem. Lack of reporting and seeking medical attention. I think workers need to document employment history and claims. Okay. Record type of duration and equipment used. Seek medical attention for pain. If injured on the job, who witnessed, where'd you get statements, etc. So there is some onus on the worker. I'm not saying everything should be on the worker, but as the Occupational Health and Safety Act in all jurisdictions have an onus on the worker, I believe that you are your best advocate, and in many ways your best healthcare professional. I think I'm done. So now this presentation will be available. Now I don't know if there's any questions. Sorry, I was getting distracted because I saw a lot of little pop-ups coming up. So
there's just one question, Carmen.
Yes.
That I think there's just one. There was a question early on if you have any stats regarding the mining industry.
It's interesting. Whoever brought that up, thank you, because there is a correlation. See, the only difficulty when you're doing comparisons, mining is a static type of environment where workers know where they go. But in the mining sector, I have seen statistics of the musculoskeletal pain issue and the underreporting, but I haven't actually seen, maybe our friends from the next presenter, when they did Nancy, whether there's been any instances of opioid-related deaths in mining. But there is a correlation on the musculoskeletal issues, and I believe the underreporting.
Okay, thank you. I think that's all the questions that we had in the chat for Carmen, Trevor.
Okay, well, great. Thank you very much, Carmen.